I'm Chief Operating Officer for the Trust, and I'm really interested in how we can keep the Trust services safe, how we can improve flow through those, and how we can make the staff experience of their work better, how they can have a manageable job. So I was looking around and I came across some theories on this, and one of them is, it's quite well known, it's the theory of constraint, and Red to Green kind of follows from that. So in my interest, I got together a group of staff, workshop really, and said, how do we achieve that? And Red to Green fell out of that, and one of the groups that were really keen on it were mental health. So the background for us as a trust is we had 3 inpatient wards, we had increasing demand, and we wanted to look at what we could do to improve that. And for me it was really important to have real clear visibility on what the blockages were, what could we really help the staff with that they deal with on a day-to-day basis. So they developed the tools for Red to Green. It was really keen that I didn't tell them how they did it, or the trust didn't, that they developed it from the bottom up. But what really made it work for me was that I get a clear escalation, so if they're stuck with something, I get to see it and I can help in the trust or wider in the economy. And I think that the staff feedback is they feel like someone's listening to them, and we can really help, and the patients get a better deal because we've cut down dramatically the length of stay, and we've been able to reduce our inpatient wards on the back of it.
So we started to do Red to Green, it's got to be about a year ago now. A lot of things happened all at the same time that meant that that we started the initiative. In essence, there was a workshop held with the staff across the units were invited to a meeting where they could explore Red to Green, what it was and what would be the benefits of that. At the same time, we had a discharge sequence from our commissioners that focused on flow throughout the pathway and kind of focus on discharge. And so those 2 reasons, the momentum behind Red to Green commenced.
Well, alongside the workshops that Kerry mentioned that we were doing, we also tried to explain to the staff in a way that what would make the ward staff, what would make our lives easier, in that if we have a patient that's on the ward that has barriers, actually whose responsibility is it to look at those barriers and sort those barriers out? So if it was housing, but it was something that the community teams needed to do, were they aware they needed to do it as soon as that patient was admitted to us? So it helped to take some pressure off the nursing staff from them doing all the jobs that were needed, and we could able to see which teams needed to sort of step in and help us out.
The other thing we did is we did a lot of education and talking to staff about the benefits to it. So I think it was a bit about understanding where the staff were at, understanding some of the feedback from patients. So we had undergone a consultation across adult mental health services, and some of the feedback that we got as part of that was kind of chimed with Red to Green. So one of the main things that came out was that patients didn't want to be on the ward longer than they needed to be. So looking at some of the patients that we had in at the time before we'd started it, you could see that perhaps barriers to discharge and a focus on that wasn't being done at the point of admission, which meant that patients often ended up staying in hospital longer than they needed to. So once staff understood those reasons and could think about the benefits to the patients, that created and energised really for engagement. I'll talk about the system, and it's thinking about how easy it is to do and how you incorporate it into the ward and other teams' routine. So we had gone to see other places. So one of our community hospitals in particular had started to do Red to Green, and they were doing it in a paper format. And what was really important for us is that we made it as user-friendly as possible, with shared ownership across all the teams. So the multidisciplinary team have access to and could look at the information that was part of it. So those were So initially, not having the systems and having to develop that and work on how that can be best implemented within the routine of the ward was a challenge initially, but one that we feel we've overcome really.
Yeah, the database we've got that we use now is so simple but so effective. It's pre-populated. Staff don't have to go in and put every patient on every day, which is what we were doing to begin with, which was took quite a long time. Now it's pre-populated. You know, if we've got any updates, they're done really, really quickly. It's basically 2 clicks and you've sorted it. It's really simple for the staff to use, and it doesn't take lots and lots of time. So they were quite happy to run with it really.
So, if I give a bit of context, initially when we started Red to Green, we had 3 acute wards, 3 18-bedded acute wards. As part of the consultation, we recognised some areas of kind of change that we needed. And in November last year, we actually closed one of our wards and moved to a new model of care. So what we've seen is that the focus for staff on discharge planning, looking at estimated dates of discharge, and that proactive discharge management has supported the flow through the kind of acute pathway.
It's also made sure that around us, not just the inpatient teams, but the community teams around us and home treatment teams and the community mental health teams they've all got a shared ownership of those barriers, and we all know what each other are doing to combat that, isn't it? That when someone would come in before, it would be, oh, you know, the barrier is they've got nowhere to live, but we would always focus on actually getting them well enough to be discharged before we then looked at where they were going to go. Now we're on it straight away as soon as somebody comes in, so that when they are well enough, everything's in place for them to be discharged straight away. And, you know, patients are quite thankful for that. They're not waiting on a ward while they're well with patients that aren't so well.
Well, what we know is that we haven't had any negative feedback to say that patients are unhappy with the fact that their inpatient stay might be quicker than historical experience of that. And at the minute we're working on getting some feedback, because obviously we've transitioned to a new model, so we're working on getting feedback on the new model. So a lot of things have happened during that phase. But also, just building on what Naomi said, the organisational feedback that we had from our patients, public and our staff was that, you know, patients didn't need to be in hospital longer than, they didn't want to be in hospital longer than they needed to be. But we've done a lot of work on ensuring patients are aware of the new ways of working. So we've got new information that we provide to them. Our everything that we do, the work that we do with our patients, informs them so that they're fully engaged with and understand the kind of process and what we're doing.
I think one of the things that's made the most difference, and the part of it, is that our working with our home treatment teams. And that I think before we would wait till somebody was well to be assessed by home treatment, and we've kind of missed it really, because you've kind of missed when they could have gone earlier from hospital. So now we explain to patients and to carers that home treatment will come and see you when maybe you're not quite ready to go. So we get those assessments in early, so that as soon as you feel somebody could go off home treatment, then they do, and I think that's made a massive difference into the patient flow and the patient experience of knowing that as soon as we possibly can, we will get them off the ward or back to their home environments. I think the main one for us getting it implemented and staff on board is, again, it's that quick, effective, simple database and system that you use. Anything that's too complicated or you have to go through a raft of questions or drop down boxes, I think you lose staff's interest and you lose why you're doing it. If it's on there, it's bright, it's vibrant, you can see you've got columns that are red, columns that are green, and you know it's all on there for you to see, and you've only got to do 2 clicks and you've filled it out. So I think because it's such a simple system but so effective, and you can look at it and know exactly where you're at, I think that was one of the main things. It's not just another spreadsheet, another database that we have to do. It actually means something because of the way it's been designed.
And building on that, I think it was feeding back to the staff some of the reasons for Red Days and the actions that we're taking, both maybe at a more local level and at a kind of more organisational level, based on the feedback that the staff are providing on Red to Green. So what we know when we look at when we analysed the data is that initially we had red days that related to home treatment assessments. So because we fed that back, that's something internally that we were able to look at and address really in a timely way. And so we don't have that as an issue anymore, do we?
One of the other issues with a lot of red days were for funding panel and getting sort of paperwork and everything into funding panel. But the community teams have now put something in place where they have those checks before we get to funding panel to make sure that it's not going to be a delay. And that's come out of how many red days we had because of that as well.
And then I suppose another tip we give is we invested a lot in coaching the staff and role modelling expectations. Because sometimes I think it's the concept of red to green can be a bit trickier in mental health, because it's like helping the staff to understand that whilst patients might be attending groups, is it something that is therapeutically needed to support them towards discharge? So we used to find patients would go to...
we'd have staff say, but it's a green day today because they've been in the OT anxiety group. But actually, if you strip it back, they have gone to the OT anxiety group, but they don't need to go for their recovery or discharge. They've gone purely because they're still on the ward. So even though they've attended the group, it's not integral to their recovery and discharge, so actually it would be a red day. And I think once we got the staff round to that way of thinking, which was hard for me and for the other ward managers to get as well, once we'd got past that, I think staff really grasped it then and we're going, actually, are we doing this as an aid to discharge, or are we just doing it because they're here? And I think it's created a lot of sort of thought and debate within the teams that, are we doing it what we should be doing, or are we doing it just because somebody's there?